Hi everyone, I'm Dr. Vaz, and the topic of today's lecture is articulators. And this lecture is for the class of 2024 Year 3 students. So, if you recall, on 2nd June, I had covered a lecture on occlusal plane orientation and phase board transfer. And after that, we covered maxillomandibular relationship, specifically, centric relationship. So the whole purpose of all these lectures or all these steps in complete denture is to ultimately make a prosthesis that is fits well in the patient mouth and is well adapted. So for this to happen, we have something called as articulators, which simulate the patient's temporomandibular joint and his upper and lower jaws. So all these steps previously, which are the centric relationship records, the orientation relationship, the vertical relationship, and the use of phase bows is all done so that we can mount the patient's models in the articulator. So let's move on to the outcomes. You are expected to be able to define and classify articulators. You should interpret the different parts of the articulators, and you should be able to infer the purpose and the uses of the articulators. You should also be able to select an appropriate type of articulator for your patient. Coming to the definitions, an articulator is a mechanical instrument that represents the TMJ and the jaws to which the maxillary mandibular cast may be attached to simulate some or all of the mandibular movements. So, simply put, an articulator is an artificial substitute of the patient's mouth, that is the TMJ and the jaws outside the patient's mouth in the laboratory, so that you may be able to fabricate a prosthesis, whether it may be a RPD, a complete denture, or a PFM restoration, or all ceramic crown, or anything, etc. So, articulation as such is the static and dynamic concept relationship between the occlusal surfaces of the teeth during first function. So articulation means the static and dynamic relationship of the patient's teeth or that of the denture teeth, and occlusion as such is the static relationship between the incising, that is the masticatory surface of the maxillomandibular teeth, or the tooth analogs, that is artificial substitutes of the teeth. So coming to the functions of articulators. As I said, the primary function of the articulator is to hold the maxillomandibular cast in the planned position as it is in the patient's mouth. You should also simulate the patient TMJ, the mandible maxilla, and the various mandibular movement to a certain extent. It should also open and close similar to the patient, that is in a hinge movement. You should be able to mount the cast for diagnosis, treatment planning, and for the patient representation. You should be able to fabricate occlusal surface of the restorations. So, and finally, we should be able to arrange artificial teeth on the articulator. We should be able to teach and study occlusion and the mandibular move. So these are all the functions or the purposes of the articulator. Now, coming to the advantage of articulator. So, what are the advantages of articulator compared to definitely the patient? So, first thing is that articulators provide a better view of the patient's occlusion, especially the lingual or the parietal side and the distribution of the mouth, which is difficult to view within the patient's mouth on a dental chair. They also help in refinement of the complete denture occlusion in extremely difficult, which is extremely difficult intraorally because of the movement of the denture based on the resilient soft tissues in the patient's mouth. And these problems are eliminated in articulator because we have hard tissue models made out of gypsum, which are anchored or solidly mounted to the upper and lower plates of the articulator. Patient cooperation is not a factor because you are working on an articulator. So sometimes in the where you find difficulty in doing even simple procedures such as taking a record in a patient's mouth, these difficulties are not encountered if you use an articulator. Of course, the chaser time of the dentist is reduced since you are doing all the laboratory phase and the procedures on the articulator. Some procedures can be given to technicians if an articulator is used. That is, you take the records, whether it is centric or eccentric records, take the impressions, and along with the articulator and the Facebook, you send it to the lab, and the entire laboratory work can be done by a third person, that is the technician. And finally, patient's tongue, saliva, and cheeks, all these things are not factors here. You are just working with the upper and lower models and fabricating the restorations that you need to fabricate. Moving on. However, articulations do have certain limitations. That is, the articulator is subject to errors of tooling and the errors resulting from metal fatigue and the wear. No articulator can exactly duplicate the patient's condylar movement. It cannot compensate for any errors in the jaw relation. That is, if there were errors in the jaw relationship, the errors will be compounded on the articulator, and there is no way to adjust or somehow compensate these errors on the articulator. And of course, point number two is that you cannot duplicate the exactly the condylar movements of an articulator, but with the advent of the fully adjustable articulators and the pantographs and the stereolithographs, we can to a great extent determine the true hinge axis of the patient's TMJ, and which is the closest thing to a natural live patient. So coming to the classification of the articulators, there are different classifications, but we'll be diving into many two types of classification. First is based on the position of the condylar elements. That is, as you know, like just like a TMJ joint, which consists of the condyle, the articular disc, the glenoid fossa, the various ligaments of the temporomandibular joints. Similarly, articulators can be divided into two categories, that is archon and non-archon articulators. Archon articulators, these are the type of articulators in which the condylar element, that is the head of the condyle, is in the lower member. Just like in natural dentition, we have the condyle is attached to the body of the ramus or the mandible, and the articular fossa or the glenoid fossa is attached to the maxilla. So in a similarly in this also we have the condylar element attached to the lower member. In the non-archon type of articulator, the condylar element is attached to the upper member. So these are broadly the differences between an archon type of articulator and a non-archon type of articulator. So moving on, this term archon was coined by Bergstrom in the 1950, which was derived from the word articulator and condyle. That is AR from the word articulator and con from the word condyle. So this was the first time somebody coined the term archon for an articulator in 1950, and this is one of Bergstrom's articulator, that is an archon type of articulator in which the condylar element is attached to the condylar support on the lower member and the fossa is in the upper member of the articulator. Next is based on the function of the articulator. The International Prosthetic Workshop at the University of Michigan in 1972 proposed a different and very elaborate classification for articulators, which is universally accepted and followed throughout the world. So in 1972, at the International Prosthetic Workshop, these are the minutes or appendix from the meeting in which the first time a comprehensive classification of articulators was given. So here we can see from excerpts from the pages of the 1972 conference, we can see here different classifications such as class 1, class 2, and so on. So basically, there are four classifications in this, that is from class 1 to class 4. Class 1 articulators are basically a simple holding instrument which is capable of accepting a static registration. That is only the upper and lower member move vertically in a vertical direction. There is no rotatory or hinge movement, and there is no eccentric movements. These type of articulators do not accept phase-bore transfers. These type of articulators cannot simulate the patient's hinge axis. We still use in these type of articulators, especially these are used by dental technicians and laboratories. So one example is a slab articulator. So this is a type of articulator in which basically the land area or the base of the upper and lower models are made with the plaster, and the plaster are extended in such a way to make a key and keyway between the upper and lower parts of the upper and lower cast. So in this way they just move vertically, that is the upper and lower member can be separated like a jigsaw puzzle in a vertical direction only. So this is a very poor form of the articulation. Type of class 1 articulators are a hinge articulator, which I'm sure some of you have seen in laboratories and dental labs, private labs. So this is the basic hinge articulator. As the name suggests, this is just a simple hinge that moves up and down. Another type of articulator is a barn door articulator, because it is called a barn door articulator because it resembles the hinges of a barn in a farm. So the difference between both of them is that the hinge articulator does not have an incisal rod or a vertical stop, whereas the barn door articulator is slightly better and it has an incisal. So next classification is a class 2 articulator. This is an instrument that permits horizontal as well as vertical motion. So here it is not just vertical motion, it to a certain extent it allows the horizontal movement of the upper and lower members of the articulator, but it is a very arbitrary. It cannot accept a phase-board transfer, and it's further divided into three categories, that is class 2A, B and C. So let us see what class 2A is. Class 2A examples are, one is a Gritman articulator by in 1899. So this is a Gritman articulator and this is a Geisy simplex articulator. So basically these class 2A articulators, the condylar and the incisal elements or the paths are determined by arbitrary values. That in the Gritman articulator, the condylar path is inclined at 15 degree. This is generally taken from a large measurement of the population. Similarly, in Guy's articulator, the incisal plane or the incisal table is inclined at 60 degree and the horizontal condylar inclination is fixed at 30 degree. So they use these values after taking measurements from a large number of population, and these were mean values. So basically class 2A articulators are articulators which are fixed, and these where the condylar and the incisal, that is horizontal, and the incisal guidance values are set based on average values. So the type of articulators you guys use in clinics are also a type of class 2A articulator. And second is the class 2B articulator. These are also articulators that are able to express simple vertical and rotary motions. But these articulators are based on the principles of theories of motion, such as the spherical theory, the Bonville's theory, conical theory. So the spherical theory. This theory was given by Monsoon. So this theory suggests that each cusp and incisal edges of all the teeth of the upper jaw, that is the maxilla, conform to a segment of the sphere which is 8 inches in diameter with its center over the glabella. And he also made an articulator which is known as the Monsoon's articulator. So you can see this articulator has a joint over here, and this represents the diameter of 8 inches. And like he mentioned, the in this articulator the spherical theory says that the upper occlusal and the incisal surfaces of the upper teeth, that is the maxillary teeth, should conform to a segment of a sphere which is 8 inches in diameter and with its center at the glabella. So this way, so you can visualize. So basically Monsoon said that the occlusal plane is oriented to the surface of a sphere which is 8 inches and with its center at the glabella. So his articulator is based on this theory. And second is the Bonville's articulator, which is based on the theory of equilateral triangle, which states that the intercondylar distance and the distance from the condyle to the center of the lower anterior teeth, that is to the midline, is an equilateral triangle. And based on this, Bonville made his own articulator known as the Bonville's triangle. So this equilateral triangle has 4-inch sides on each side. And the third theory was the conical theory given by Hall in 1915. So this is Hall's articulator based on the conical theory. So what did Hall state? Hall stated that the lower teeth, that is occlusal incisor surface of the lower teeth, move over the surface of the upper teeth as they are moving over the surface of a cone, generating a 45-degree angle with the central axis of its body, and with the cone tipped at 45 degree, that is it is horizontal to the occlusal plane. So something like this. So this is conical theory of Hall, which states that the occlusal plane lies at the surface of a cone which makes a 45-degree angle with its central axis. So this was class 2B, and the last is class 2C. So this articulator was given by House, and it is known as the House articulator designed in 1927. So this articulator is similar to what we would call centric relationship records, that is dynamic records. So as you would have know, in In the last lecture, that is maxillomandibular relationship, we had covered needle house method of recording the centric relation or the protrusive and retrusive motions. So in this, what we call compound rims are fabricated with four stylus fixed on the mandibular rim, and wax rim or the compound rim in the lower, and then the patient is asked to do various movements, and these diamond shaped tracings are recorded. So this house articulator then accepted these tracing to mount the maxillary and the mandibular articulator. So needle house tracing method is used for the articulation of the models in the house articulator only. So next, coming to the class 3 articulators. So these are articulators slightly better. They accept the eccentric motion, that is protrusive and lateral records, and also allow the adjustment of the movements according to the patient. But only a part of the patient's condylar movements can be simulated here. Hence, they are categorized as semi-adjustable. These type of articulators accept protrusive record, lateral record. You can adjust the horizontal condylar guidance, the lateral condylar guidance, the incisal guidance, but to a certain extent, and not accurately as it is in the patient, because these articulators accept static records and not dynamic records. And but the key difference between class 2 and class 3 is that they accept the phase code transfer, and these are the articulators that come under the classification of arcon and non-arcon articulators. So there are two articulator categories in this class 3, that is class 3A and class 3B. So let us see what class 3A is there. Class 3A is the articulators that accept only protrusive records. They do not accept lateral, that is laterotrusive records, and the laterotrusive condylar guidance is calculated by a formula which was given by Hanau, that is where lateral condylar guidance is equal to horizontal condylar guidance divided by 8 plus 12. So we can determine the lateral condylar guidance using this formula, and it is set here on the base of the lower member. You can see here some readings. So these are for the lateral condylar guidance which we obtain from the formula. The horizontal condylar guidance is set by the protrusive records which are obtained from the patient. So the example of these are Hanau model H and H2, Dentatus and Bergstrom, and these articulators accept Facebow. And this what you are seeing here is a what you call a non-archon type of articulator, because here the condylar sphere is attached to the upper member and the condylar pathway is in the vertical rod that is in the lower member. So next, coming to the class 3B. Examples of class 3B are Hanau kinescope, and this is a knees articulator and also panadent articulator. Now the key difference between class 3A and B is that class 3B also accept lateral records. Class 3A only accept protrusive records. So next, coming to the class 3, that is class 4, the final classification of the articulator. These articulators are categorized as fully adjustable articulators. The class 3 was a semi-adjustable articulator, whereas class 4 is fully adjustable articulators. And these articulators are only archon type of articulators, and they even have adjustable intercondylar distance. So these articulators are again classified into two categories, class 4A and B. The key difference here is that these type of articulators accept three-dimensional dynamic registrations. Not They do not accept what we call static protrusive and lateral protrusive records, but they accept dynamic records from the patient using special instruments that are known as stereographs and pantographs. We'll talk about them later. So some examples of these articulators are the store articulator and Denar D5A. So these are articulators that accept a phasebow transfer. They are capable of accepting the dynamic records, and the intercondylar distance is also adjustable in these articulators. So next, coming to the class 4A, that is the first category. So in this category we have Swanson's TMJ articulator. This is the Swanson's TMJ articulators. So these articulators accept dynamic records, that is they accept stereographic recordings made from the patient, and then depending on these stereographic recordings, the condylar, that is horizontal condylar guidance, the lateral condylar guidance, and the incisal guidance is customized on the articulator. So here you can see that first, just like we do a Facebook transfer using a bite fork, on a bite fork, the impression material is attached and the Facebook transfer is done using the bite fork. This is to mount the maxillary model on the cast on the articulator. After this, these in the second picture, what you see are something called as clutches, which are made out of composites or resin material. These clutches are then attached to the upper and lower record bases, and the upper clutch has these five studs or styli, and it makes the diamond shape or the arrow, typical arrow tracing for the protrusive, centric, and the laterotrusive guides or the mandibular movements. After this, over these arrows, acrylic or self-cure acrylic in the dough stage is placed, and these clutches along with the acrylic are then placed in the patient's mouth, attached to the upper and lower wax rims, and the patient is told to perform all the mandibular border movements, and patient performs dynamic water movements which shapes these acrylic records, and then these clutches are then attached to the upper and lower member of the articulator, and with the help of these records we customize the horizontal condylar guidance, the incisal guidance. So this is done by placing acrylic in the sleeves of the condylar guidance, and when the critic in the door stage, using these records, the operator does forceful protrusive and laterotrusive movements, and depending on the shape of these records, the interocclusal records, the acrylic or the horizontal condylar acrylic custom guides are prepared. And after these, the horizontal, the lateral, the incisal guidance are set. Something like this. It is little difficult to explain to you guys because these are things that cannot be learned or remembered in one time, and unless we can show it by doing a demonstration, a practical demonstration, difficult to say. But this is, you can see acrylic is placed in the condylar sleeves, and using the records and the clutches, the mandibular movements are done, that is protrusive, centric, laterotrusive movements, and the acrylic is shaped. So these are the customized condylar guides for that specific patient. And in the similar way, we also get, we place acrylic on the incisal table and we get a customized incisal table. So we have, this is the incisal guidance, this is the horizontal condylar guidance, and also depending on this we adjust the lateral condylar guidance. So next is the class 4B. So this type of articulators, they do not accept stereographic tracing, but they accept pantographic records and tracing. So if you remember in my last lecture, that is on maxillomandibular relationship, I had showed you what a pantograph is and what are pantographic tracings. So basically pantographic tracings are like we do tracings on a graph paper and with a butter paper over it. So these are just two-dimensional tracings which are obtained similar to Gothic arch tracing in the patient's mouth, and these are obtained in all the three planes simultaneously by asking the patient to do dynamic mandibular movements in all the directions. So these you can see horizontal tracings, these are sagittal tracings. So these are obtained with a styli and a graph on the pantograph. So this is an electrical pantograph with flags attached on the side on the of the patient's face, that is in the sagittal plane, and over this flag the graph paper is attached. And of course, since this is an electronic pantograph, we do not need graphs over it. So, and the styli makes the recording of the records the patient's mandibular movement, capable of accepting these recordings. So that brings us to the end of the class 4 type of articulators. So let us come back again to the class 2A type of articulators, which you guys use in the lab over here. So this is, so you guys, I think, are able to recognize these are the articulators that you use in the laboratory in the prosthetic department here. So this is a 3-point average mean value articulator. So the 3 points are the incisor table and the two condylar studs over here. And this is called as average because the intercondylar distance is set to an average of 110 mm, and the condylar guidance and the incisor guidance values are also set to mean values of the population. So this is the upper member, this is the condylar shaft, this is the lower member, this are the additional pin for orientation of the occlusal plane, this is the incisal rod, this is the incisal pin, this is the incisal rod adjustment screw, this is the incisal table, and these are the upper and lower members. So so you can see here these condylar shafts are set at a fixed average distance of 110 mm, and this is the horizontal condylar guidance set at 30 degree, and it has a spring so that you can do some to some extent protrusive movements. So this is set at 30 degree, and that's why it is a class 2A type of articulator, which incorporates arbitrary values. And the incisal table is set at a uniform 5 degree, or so in some articulator it will be set at 10 degrees. So this was the articulator that you guys use routinely in the lab and in the procedure department. So next, coming to the laboratory procedure. So I'll be briefly brushing through the laboratory steps involved in the mounting procedure with the semi-adjustable articulator. You guys are already familiar with the mounting procedures with the class 2 articulator. So basically, I'll just show in a nutshell how you do the mounting using a phase bow in a semi-adjustable articulator. So this is a dentatus semi-adjustable articulator. This is the upper and lower member. These are a condylar sphere. This is the condylar path. These are the lock nut for stabilizing the condylar sphere. This is the incisal table. This is the curved incisal rod. This is the incisal rod adjustment screw. And these are the condylar post. So moving on. So this is a 2D sketch of the same dentatus articulator. So first step, before we do the mounting of the maxillary and mandibular wax rims or the maxillary mandibular cast, we have to zero the articulator. This is something like, how we reformat or factory reset a phone. That is, you delete all the data or zero all the readings previously that were there. So in this, the horizontal condylar guidance is set at 40 degree, and the lateral condylar guidance is set at 20 degree, and the incisal guidance is set at 0. So this is called as zeroing of the articulator. After this, the articulator is ready to accept the phase. So after this, the phase bow is attached to the articulator. This is the incisal orientation plane. So, and these are the two earpiece which go and attach to the horizontal condylar elements on the articulator, and the maxillary cast is along with the bite fork is using this as phase bow, and the mounting jig is mounted on the upper member of the articulator. After mounting of the max rim, the upper and the lower wax rim, and along with the model is placed on the maxillary wax rim, and these are sealed with the help of a centric record which is obtained with a Gothic arch tracer. So you can see here this is the extraoral Gothic arch tracer, and at the centric position a plaster index is made, and this is used to orient the mandibular and the maxillary cast. After this, the plaster is poured onto the base of the mandibular cast, and it is attached to the lower member of the articulate. So this brings us to the end of our lecture. So here you can see all the various type of articulators, from a simple hinge articulator to a Geissy simplex articulator. This is house articulator, which uses the needle house Patterson method, and that after that we have the class 3A, class 3B, and class 4 articulators are Dinard D5 and Stratos 300. And nowadays, because we have virtual impressions, virtual planning of the any type of processes, and we have digital CAD CAM milled dentures and ceramics such as zirconia, Emax, Empress, all these things. So we also have something called as virtual articulator. So that brings us to the end of our lecture. So